Good morning, everyone. So it's 9:45. We'll get started. I'm Dr. Sophie Corvo. I'm a CF physician at McMaster University, and I have my co-moderator here, Dr. Margaret Rosenfeld, Professor of Pediatrics at the University of Washington. So thank you, everyone, for joining us today in this workshop, Lung Health in a Changing World. We have 5 speakers, each of whom will be presenting their own abstract. They'll have about 15 minutes for presentation, followed by 8 minutes of questions. So for those of you who have questions, we'll be doing it right after each speaker session. You'll be able to come up to the mic. Alternatively, if you sign into this session on your app, you can ask a question directly. So I will be keeping an eye on the app, and I'll be able to ask questions for you. So we'll start with our first speaker, Dr. Julie Semanchuk. She is a Chief Resident Respirology Fellow at the University of Toronto. So welcome, Dr. Semanchuk.
Okay, thank you for that introduction, and thank you for the invitation to speak today. I am excited to tell you about my work with the Cystic Fibrosis Registry Global Collaboration. So without further ado, let's explore the impact of COVID-19 on lung function and nutritional status, a global observational study. I have no conflicts of interest to disclose. So the reason why this topic is so important, specifically in cystic fibrosis, is that we know pulmonary exacerbations can result in lower lung function and poor nutritional status. So this graph on your right was taken from a retrospective cohort study that compared the rate of lung function decline in individuals based on the number of exacerbations they had per year. You can see that with more exacerbations, there is a greater rate of lung function decline. Now, viruses can cause pulmonary exacerbations, but they don't always. The data around viruses changing lung function in the cystic fibrosis population is conflicting. There was a study done during the H1N1 pandemic, and reassuringly in this situation, lung function did not drastically change in these individuals. However, the H1N1 pandemic was different than COVID-19 for a number of reasons. It primarily affected individuals less than 30 years of age. In the majority of cases, these cases were mild in severity, and this pandemic only lasted about a year. So this leaves us with the question, what are the effects of COVID-19 in cystic fibrosis? And in case you needed a reminder, on March 11th, 2020, COVID-19 was declared a pandemic worldwide. This is a graph showing the hospitalization rates by country over time. And you can see that as hospitalization rates increased around the world with COVID waves, so did the fear of those living with chronic lung diseases, such as cystic fibrosis. So what we know about cystic fibrosis and COVID-19 to date has actually recently been summarized in a nice systematic review. This review included the results of 9 observational studies, and these studies mainly focused on characterizing who gets the infection and what are the risk factors for severe acute infection. Some risks that have emerged include lower lung function, increasing age, CF-related diabetes, being underweight, and pancreatic insufficiency. There was actually not enough data on modulator use to fully understand their impact on acute infection. Now, the longer-term outcomes following COVID-19 infection are less understood. The study with the longest follow-up to date included about 66 individuals, and at 6 months, they showed there was no change in time to first pulmonary exacerbation, and there was no change in lung function when they compared this group to individuals who did not have COVID-19. But I think you'll agree with me that the longer-term outcomes require further study. So our objective was to determine the impact of COVID-19 infection on lung function and nutritional status in cystic fibrosis. So to look at lung function, we looked at FEV1 % predicted, and to look at nutritional status, we looked at body mass index, or BMI. We looked at the value of FEV1 and BMI before infection and after infection, and then we looked at the mean change. But we also looked at the rate of change before infection and after infection, because it is entirely possible COVID alters the natural history of disease, and we could miss this by looking at the mean change only. So to answer our objective, we harnessed the CF Registry Global Collaboration Group. A COVID-19 case report form was developed, and we collected data through either an Excel spreadsheet, a REDCap database, or through registry extraction in 47 different countries. And the method used in each country is outlined in this map here. And one of the really unique things about this collaboration is that we've included countries that have not typically been involved in research prior. So the data that we actually collected included individuals who had COVID-19 infection from January 2020 to December 31st, 2021, diagnosed either by positive rapid antigen testing or PCR. We collected data on CFTR modulator use. So anytime we collected data on FEV1 or BMI, we recorded whether individuals were using modulators and what modulator they were using. We excluded transplanted patients. Our outcomes of interest, as I mentioned, were FEV1 and BMI, but specifically we were interested in these values 1 year prior to infection date and 1 year post-infection date, up to and within. We used paired t-tests to look for the changes in ppFEV1 and BMI. And then for our rate of change analysis, we used a random intercept regression model into 2 specific cohorts. And I'll elaborate on the rationale for using these 2 cohorts shortly. But in a cohort that was not using modulators, and in a cohort that was continuously using elexacaftor, tezacaftor, ivacaftor. And our models were adjusted for age, sex, infection year, and country income status. So this meant we had 2 separate cohorts, our FEV1 cohort and our BMI cohort. Our FEV1 cohort included individuals aged 6 years and above because this is when pulmonary function testing becomes reliable. Our BMI cohort included individuals of all ages. Now, to be eligible for each of these cohorts, the requirement was at least 1 pre-infection measurement, again, that fell within the 1 year time period prior to infection, and at least 1 post-infection measurement, again, falling within that 1 year post time period. We excluded values that were outliers. So this left us with a total of 3,957 individuals in our FEV1 cohort from 30 countries and 4,506 individuals in our BMI cohort from 33 countries. Some countries were excluded due to incomplete data. As a sensitivity analysis, we did include individuals with at least 2 pre and 2 post measurements, and those were used for sensitivity analyses. So this is a graph summarizing our COVID-19 infection data. The number of COVID-19 cases is on the y-axis, with infection date being on the x-axis. And as anticipated, our COVID waves align with the emergence of new variants and really reflect global trends. So this looks similar to the graph I showed you earlier. So this was reassuring that we were gathering the data we desired. And here is the summary of our patient demographics in both cohorts. In general, these were young patients with a median age of 22. They had good lung function with median ppFEV1s around 82%, normal BMIs around 21, and about 85% had at least 1 copy of the F508 del mutation. Moving forward, I will walk you through the results of our lung function analysis, but I would like to reassure you the same process was done in our BMI cohort. So for our whole cohort, the pre-infection mean FEV1 value was 79% predicted, and our post-infection mean FEV1 value was 80.4% predicted. So this meant following COVID-19 infection, the mean change in lung function was positive 1.4%. So this was surprising for a couple of reasons. Number 1, it was positive. And number 2, it was quite small and not clinically significant. We did a number of subgroup analyses, and we actually found similar results across the board. So in individuals who were male, in individuals who were female, in individuals who had diabetes, who didn't have diabetes, there was a small mean difference after infection that was positive in most cases. But there were two main exceptions that stood out to us. So in individuals who had baseline FEV1 values below 40%, the mean difference after COVID infection was actually positive 3.4% predicted. And in individuals from low to middle income countries, the mean change in lung function after infection was negative 3.8% predicted. So one thing that might be crossing your minds is this because more patients with low FEV1 were getting started on modulators, and that's why their lung function was increasing? And does this decline in low to middle income countries reflect the lack of access to modulators? We did, of course, have information on modulator use at varying time points. So modulator use here is on your y-axis with date on the x-axis. The things that I really wanted to highlight here are that this dark purple color, which represents the individuals who were not on modulators, steadily decreased throughout the study period. The individuals who were on ETI, represented by this nice lime green color here, disproportionately increased compared to all other subgroups as time went on. And now here are a few bar graphs showing pre-FEV1 values represented by this dark blue color and post-FEV1 values represented by this yellow color for a number of cohorts based on their modulator use. So in the cohort that did not use modulators at any time point, there was minimal change in lung function following infection. In the individuals continuously on ETI, there was also minimal change. And now this third group is perhaps the most interesting and represents anyone who changed modulator use. So this included individuals who were not on modulators initially and then went to modulators at some point in the study. It also includes individuals who were on one modulator and then switched to another at a time point in the study. And here we can see this is the group where the most positive change in lung function following COVID-19 infection was seen. So to us, this clearly represented that modulator use was a confounding factor. Moving forward, to truly understand the impacts of COVID-19 on lung function in cystic fibrosis, independent of modulator use, we focused on the ETI and no modulator cohort. And I will show you our results. So there were 804 individuals in the no modulator cohort, and the change in lung function trajectory was 1.342% predicted per year, and this value was not statistically significant. So to better understand this, here is a plot showing the values that contributed to these results, and this plot also shows you the rate of change lines. They are the ones that are located horizontally in this graph. So on the y-axis, we see ppFEV1. On the x-axis, we see years from COVID-19 infection. And so this shows that we had data spanning the spectrum of disease. And this also shows that these lines are quite flat and there is no significant change after infection. If you really want to zoom into the lines, you can see there was a slight attenuation in the rate of decline. However, again, these results were not statistically significant. We had 1,285 individuals in our ETI cohort, and lung function trajectory changed by a rate of negative 0.742% predicted per year, and this was also not statistically significant. Again, our data did span the spectrum of disease. When you zoom into the rate of change lines, we can see there is an attenuation in the initially positive slope, but this is minimal and not significant. So we also found that there was no evidence that sex, income status of country, or vaccination status modified the impact of COVID-19 infection on the rate of lung function decline. Sensitivity analyses using individuals with at least 2 pre and 2 post values showed similar results across the board. For our BMI results, groups were analyzed in 2 different age categories. In the age greater than or equal to 18 cohort, there was a mean BMI difference of positive 0.4 kilograms per meter squared following infection. And in the age under 18 cohort, the mean difference was positive 2.8% following infection. These were BMI percentiles. There was no significant change in the BMI trajectory following COVID-19 infection in the ETI or no modulator cohort. So we were faced with a number of limitations in the study. There was missing data, but our sample size was large and therefore likely still representative of the global experience. The excluded cohort overall appeared similar to the included cohort. We know this because we looked at the demographics of these individuals. Modulator use was, of course, a confounding factor, but we did our best to account for this by analyzing the no modulator and ETI cohorts separately. The effects of COVID-19 on other lung function parameters, such as diffusing capacity, total lung capacity, still remain unknown. And then our study was limited to 1 year following COVID infection, so longer-term effects could remain unknown, but we feel this is probably unlikely. So overall, this is good news. We found there was no significant difference in lung function or BMI following COVID-19 infection in the cystic fibrosis population. We do still have other variables in our cohort we plan to take a closer look at, so we know who needed antibiotics for a pulmonary exacerbation within 3 months. We know who received COVID-specific therapies, and we actually have about 110 pregnant individuals in each cohort that were included that we will, again, take a closer look at. We also have a completely separate group of patients with CF who have received transplants that we plan to complete a similar analysis on. So I really wanted to end with this. In the novel The Plague by Albert Camus, you are thrown into a town dealing with the bubonic plague in the 1940s. At the end of the novel, the main character reflects and hopes that his recollection of what needed to be done to control the epidemic will serve as a reference for future generations. My hope is this project and methodology serve a similar purpose. Should threats to the CF population arise in the future, the global group will be well equipped to unite and answer questions on critical outcomes. So thank you so much to everyone who is part of the global collaboration group. Thank you to all the individuals living with CF across the globe who have contributed data to this. And a special thank you to Yumi, Susan, Stephanie, and Anne for your mentorship, dedication, and hard work on this project. And thank you all for listening.
I don't know how to turn that on.
Thank you very much, Dr. Semanchuk. So now we invite anyone who have any questions, feel free to step up to one of the mics. Alternatively, if you sign into the app, we'll be monitoring the questions as well. So we have about 6 minutes for questions. One question we see from the audience. Was there any data on vaccination status?
Yes, we did have data on vaccination status. We used this data to see if it did impact the change in lung function decline, and we actually found that there was no significant effect. Now, this being said, approximately 30% of our data was actually missing information on vaccination status. So that is one of the limitations. The data was there and we analyzed what we could. But this doesn't mean that people shouldn't get vaccinated. It's just what this study showed, we were limited by missing information.
Yes, please go ahead.
Felix Ranch in Toronto. Nice data. So I was wondering, because there could potentially be an impact that patients that had COVID received more intense treatment in other areas like mucociliary clearance and antibiotics, anti-inflammatory drugs such as azithro. Did you look at this, and could that have an impact on the data that you presented?
So Do you mean COVID-specific therapies or?
No, I mean other CF-related therapies that just
okay.
intensify in this situation.
I see. We actually didn't, as part of that initial spreadsheet, collect data on who was on kind of some of those add-on therapies like azithromycin or inhalers. And we did actually, like as we were analyzing this data, we had wondered if we, had collected information on those things, but we did not.
Okay.
Yeah. But thank you for that question.
I have a question.
Oh,
Sorry,
yes.
you can't tell where I'm coming from. My apologies. Thank you. That was a really rigorous analysis and a beautiful presentation. One of the potential unmeasured confounders would be that during the lockdown, our CF patients were very concerned about getting COVID, and so they really took lockdown seriously on average, which then exposed them to less viruses, which could also cause FEV1 to decline over time. You limited your analysis to COVID-exposed individuals, but there's a whole other group of those who, to the best of our knowledge, did not have COVID. And you could look at a similar analysis with rate of decline, obviously not related to the COVID infection itself, but during the same time period, to see if that was also lower than anticipated and compare it to the rate in these folks to get at that unmeasured confounding.
Yeah, we actually thought about this because this was something that other people have raised in the past. Was the pandemic itself a confounding factor? And it would be helpful to have that group of individuals who didn't have infection to look at their rate of decline and their change in lung function. Another way that I've kind of thought about it is, maybe the pandemic helped control for all of the other confounding factors is one way to look at it. And the direct impact of COVID-19 did not change lung function. Of course, in that situation, it's not as reflective of the real world experience, which is what clinicians want data on. So by having that control group, that would have been helpful. I do still think that because we have this cohort on, and we know that there's some individuals who required antibiotics within 3 months of an exacerbation, maybe this will be more reflective of the non-pandemic times, maybe, and we can see what the data shows for these individuals.
Thank you.
Yeah, no problem.
Another question from the audience: was any information collected on other concurrent infections such as influenza, RSV, and so on?
Yeah, that's a really good question, actually. We did not. I presume that might have been something that would have been feasible, because I'm just thinking as patients were admitted with COVID, we did swabs for all kinds of viruses, but I don't know. I think there might have been a lot of missing data associated with that if we tried. Regardless, we did not have that data available.
Another question, was GLI 2012 reference equation used, or was the GLI global race neutral reference equation used for the ppFEV1 collection?
So
just with regards to the reference equations for the spirometry measurements, whether it was the GLI 2012 or the global race neutral reference equations.
It would have been, so these were collected from individual sites filling out the spreadsheet, so it would have been whatever the center was using, so the 2012. These are not the new updated spirometry values. That's a very good question, but no, these would have been from the 2012. Sorry, that took me a second to just process.
And maybe I'll ask one last question from the audience. Do you have any data on long COVID?
No, we don't. Again, we have this whole cohort available, so it's something that we could certainly look into, especially as time progresses and COVID is not going away. So I think that could be a great next project for the Global Collaboration Group. So thank you for ending with that question.
Thanks again.
Thank you.
So our next speaker is Dr. Leah Cohen from University of Texas at Southwestern, probably happy about last night's turn of events, who will be speaking on a multi-center retrospective analysis of the clinical efficacy of ETI in people with CF and advanced lung disease, which is a follow-up study after 2 years.
Good morning, everyone, and thank you to for everyone who invited me to come and talk. So as they said, this is a multi-center retrospective analysis of the clinical efficacy of elexacaftor, tezacaftor, ivacaftor in people with cystic fibrosis and advanced lung disease. And this is actually a follow-up study looking at 2 years of treatment. I have nothing to disclose for this presentation. So as everybody in the room knows, elexacaftor, tezacaftor, and ivacaftor was studied in people with cystic fibrosis with both single copy of delta F508 as well as homozygous for delta F508, and they saw an improvement in lung function, an increase in body mass index, and a decreased rate of pulmonary exacerbations. What's important to remember is that both of those trials excluded people with CF and advanced lung disease. And how do we define advanced lung disease? You usually have to meet one of the following criteria. So your baseline lung function needs to be less than 40%, again, measured as percent predicted FEV1, not during an single exacerbation, referral to a lung transplant center, previous ICU admission for respiratory failure, chronic hypercarbia, resting hypoxemia, pulmonary hypertension, severe functional impairment, or 6-minute walk test less than 400 meters. So this was the original paper that we published back in December of 2020 in the journal Cystic Fibrosis. And this just published data about the short-term effect of triple combination therapy on lung function and transplant planning in people with CF and advanced lung disease. There were 3 centers, 3 adult centers, our UT Southwestern, Medical University of South Carolina, and the University of Alabama, Birmingham that submitted all of our data. And then our inclusion criteria at the time were adult patients, and they were started on triple combination therapy after FDA approval, and then they had to have met criteria for lung transplant or advanced lung disease. We excluded those who were on ETI by the Compassionate Release Program. So in our original study, I'm going to go through this really quickly, but this was our table 1. We had about 50 patients, about half were female. We had both homozygous and heterozygous patients for delta F508 included. Most were treated within about a month of, and then their baseline FEV1 prior to starting the medication was about 32%. And I'm going to go ahead for more comprehensive. So what we found was that lung function improved by an average increase of about 8%. And as you can see on our figures here, we have, this is pre-triple combination therapy and post-triple combination therapy. So you can see each individual subject's improvement, or in one person's case, decline after starting triple combination therapy, and this was statistically significant. And over here we have a waterfall plot showing our individual subjects' response, some having a very robust response and only one having a decline. So this was great information to tell everybody. What we do know is that our patients with advanced lung disease do respond to well to triple combination therapy. So then the question becomes, what about long-term data? So there's only been one clinical trial that looked at the effect of ETI in a 48-week time period in Italy. They only used patients who were homozygous for delta F508, so they had a very low N of about 26 patients. But overall, that they showed that lung function actually continued to increase from baseline up to 48 weeks of therapy. So then we decided to look back at our original cohort and see, well, what's happening after 2 years on the medication. So again, this is a follow-up of our original cohort, adult patients, both heterozygous and homozygous for delta F508 from the same 3 centers. We were looking at the impact of 2 years of ETI and lung function as our primary outcome, and then our secondary outcomes were also BMI, pulmonary exacerbation rate, lung transplant status, or death. So for our study design, again, this was a retrospective cohort study of adult patients from all 3 centers. They were started on triple combination therapy between October 2019 and January of 2020. We excluded our patients on the early access program. Again, they had to meet the foundation guidelines for CF-related ALDs, and then we also CF-ALD, and then we also looked for marked presence of high-risk features, so colonization by non-tuberculous mycobacterium or Burkholderia species, history of massive hemoptysis, history of pneumothorax, and of course CF-related diabetes, as that impacts their overall health and mortality. For our statistical analysis, we did a continuous paired variables comparing using two-sided t-tests, and then we did an ordinal paired response variables compared with non-parametric Wilcox signed rank tests of location, and p-values were considered significant if they were less than 0.05. So how did we assess lung function? So their baseline lung function was measured from their most recent spirometric measurement prior to initiation outside an exacerbation period. And then our follow-up periods was the first spirometric measurement after starting the medication, and then again at 12 months, and we gave a leeway of plus or minus 3 months to get enough data, and then again at 24 months. And then BMI was collected at the same visit at the same exact visit that they got their spirometry done. We also looked at pulmonary exacerbation rates on an annual rate, and we defined exacerbations as receiving oral or IV antibiotics. We also collected their baseline demographics and transplant-related outcomes. So, of course, this occurred during the COVID-19 pandemic, and so it's important to remember that our overall N from our initial study actually dropped, and some of that was because we were having telehealth visits or patients transferred centered or were lost to follow-up. And so we analyzed 63 people at the first initiation, and we excluded one person who had massive hemoptysis because he had a very positive, very good lung function to begin with, and felt that he would skew some of our data. And then for the 12-month analysis, we had 7 people missing, so they did not show up at all within a 1-year period, and then 1 person was transplanted, so we excluded them. And then at the 24-month period, we actually had 1 person decide that they were finally ready to and able to come back, and I know this because it was my patient. And so we got 1 patient back for the 24-year data. And here are our baseline demographics. So this is just from the initial study, just from the initial group. The average age was about 32 years, 52% were female. Again, we had both heterozygous and homozygous for Delta F508 patients included. Their baseline lung function was mean average of 34%. High rates of Pseudomonas colonization, high rates of high-risk features, and again, that included history of pneumothorax, massive hemoptysis, or colonization with non-tuberculous mycobacterium or Burkholderia. Their exacerbation rate per year prior to starting medication was about 3 annually. Their BMI was not too bad on average at 21.5. About 50% had CF-related diabetes, and all were pancreatic insufficient. So now to the meat of our project, looking at our results. So over here on this table, you can see these are our baseline demographics after, so this is prior to starting ETI. This is what happens at 3 months, 12 months, and 24 months. So this data was the data we originally published, so we did see that lung function went from 34% up to a mean average of 42%, and that was statistically significant, again, after initiating the medication. And then what we saw at 12 months and at 24 months, and all of these p-values are actually compared to baseline, we saw that lung function basically was sustained at both 12 months and at 24 months. And I will show this graphically in the next slide. We saw similar responses to BMI, where BMI went slightly up at 3 months, and then actually continued to go up at 12 months and maintained at 24 months. And then the annual exacerbation rate, again, baseline was about 3 per year. So at 12 months, that dropped to about 1 per year. And then it stayed about the same, although a little bit up at 2 years. In our cohort, we only had 1 patient who was transplanted, and this one did not respond very well to triple combination therapy upon its early release, and the decision was to go ahead and transplant. And we had one patient who passed away during the 2-year mark. So here's our data represented in a graph, as a graph. So we can see lung function on the lung function here, and then all the different time periods. And again, we plotted each person's lung function individually. This is their mean lung function, and then you can see the trend represented by the blue line. And then again, statistical significance was compared to baseline. So we saw statistically significant changes in lung function between baseline in 3 months, baseline in 12 months, as well as baseline in 24 months. This is our waterfall plot that just looks at change in lung function from baseline to the 24 months, comparing it to the last group. We do see some patients that have had a little bit of decline, but mostly everybody's lung function stayed relatively up. Here are our BMI results, a little bit more scattered. But again, you can see BMIs from baseline went up at 3 months and then continues to go up at 12 months. And then between 12 and 24 months, relatively the same. Again, statistically significant. And then finally, our rates of pulmonary exacerbation. So we see that at baseline, again, these numbers are small because they're annual rates. We have a decline at 12 months and a stability overall at 24 months. So some of the discussion points that this brought up is that we saw, so people with CF and advanced lung disease who started on ETI had statistically significant increase in lung function from baseline. And what was important to remember is that this increase in lung function was sustained over a 24-month period. We saw the same trend in BMI. So BMI went up at 3 months and was sustainedly increased at 12 and 24 months. And then we saw the opposite, which is what we would expect for pulmonary exacerbation rate, is that it went down. So then the question becomes, as I've talked to a lot of my colleagues, is should we be updating our advanced lung disease and lung transplant guidelines? So as I mentioned in the guidelines, if your lung function was less than or equal to 40%, we would start having conversations with patients about transplant. Usually when we're referring people for transplant, we're considering mortality within a 2-year time period. And our study was within a 2-year time period. And fortunately, we actually did not send anybody for transplant really in this group. And we only had one patient pass away. But I think what we really need to look at is considering transplant referrals based on individual response. If you look beyond this data, so I know these patients quite well. We have had, if you go beyond 2 years, we had a patient who did get transplanted eventually for massive hemoptysis because she would continue to hemoptysize, and we felt that that was the right decision for her. We also know that we have some other patients who were not in this original cohort who are now meeting criteria for advanced lung disease and are being considered for transplant. So we still need to consider counseling our patients based on their individual responses. And I think the other thing that we need to pay attention to is the rise in body mass index. So our lung transplant center says if your BMI is greater than 30, no lung transplant. And I don't want any of our patients to get to that point where if they were potentially needing a lung transplant, that their weight was an issue. So development of obesity could also limit future lung transplant options. So our study limitations, of course, is the retrospective design of our study and the still relative short follow-up period. We hope to do additional studies looking at somewhere in the 3 to 5 year post-ETI may provide additional insight. And at this time, I'd like to acknowledge my colleague, Dr. Gregory Raytai at UT Southwestern, for helping me with the project design and collecting the data, Dr. Christina Mangora, who's from MUSC, and Dr. Brian Garcia at UAB, to our adult team centers, and then to people with CF. I'll pause for questions and answers.
Thank you so much. This presentation is now open for questions.
Hi, Felix is very tall. Brad Kwan, Vancouver, Canada. I was just a very, very nice presentation. I was just wondering if you collected any medication adherence data on nebulized therapies, because I wonder if there is some heterogeneity. Like we've noticed at our own center, even in the more advanced lung disease group, they've stopped all their nebulized therapies, which frightens me because we don't have data long term. And Trikafta is great, but is it enough to prevent them from needing transplant in the future?
We did have the data of at least who was being prescribed their airway clearance, but we didn't have any. It was very difficult for us to parse through that data to then say who was adherent, because as we all know, patients tell us they're doing things and then they're not. But it is definitely something that I think we should go look back at, because I can speak also from experience that a lot of our patients have stopped doing their airway clearance because they don't feel that they don't feel the effects like they used to on ETI. I will say most of these patients, at least during that 2-year time period, were still kept up with a lot of this stuff. And I think in the last year or so, we've seen their exacerbation rates go up because they're not being compliant. And I think it would be definitely something that we could look at least based on probably getting some prescription refill data, and then some of the other adherences like their vest outputs and things like that.
Okay, thank you.
I have 2 questions. The first one is around safety. Did you gather data on who had to stop ETI due to intolerance and the reasons?
We did. We didn't have any patients that had to stop medication at that point in time. So that was actually some good news. Again, it's a very small cohort. So
still, that's great news. And then the other question I have is, would you consider undertaking a similar, though somewhat simplified, analysis using the entire US CF patient registry?
I would love to do that.
We could talk offline about that if you'd like.
Yes.
And if anyone has questions in the chat, remember we are keeping an eye on that. One thing that I had a question is, how did you guys define pulmonary exacerbations? Because it can be tough in the era of modulator therapy. My own personal experience, as soon as someone might cough or have a bit of sputum, suddenly the question is, okay, is this an exacerbation?
Yeah, so we went through the medical record and looked at who was on IV antibiotics or oral antibiotics prescribed. I will say the oral antibiotics was a little bit more difficult to tease out because obviously some were prescribed orals and then may have been put on IVs. If they were started on orals and went to IVs, then we considered that an IV. And the reason that we didn't do hospitalizations is because our center does a lot of outpatient home IVs, and I didn't want to exclude those patients.
Did you account for Trikafta adherence in this study?
Same question.
We did not account for Trikafta adherence in this study, so we hoped that our patients were continuing to use their medication. Although I will say most are, but I'm sure there'll be a few that surprise me.
Did you perform a paired analysis between the 3-month and 24-month outcomes to outrule any decline in this period?
What decline? Sorry.
Did you perform a paired analysis between the 3 and 24-month outcomes to rule out any decline in this period?
We did. So that information would be here looking between the 3 and 24 month. I have that data not actually represented on this actually, but we have it. I have it in our, in what we've done. And it was, there was no statistical significance between looking if you compared 3-month to 12 or 3-month to 24. It was really only comparing it to the baseline. But again, I think what's more important was to understand what was happening once we saw that initial increase was what was going to happen over time. But yes, if you actually compared 3 months to 12 months and 3 months to 24 months, there was no statistical difference between lung function.
I'll keep going with the online questions then. Do you know if the subject who passed away was the same person whose FEV1 declined?
I don't, because I was blinded to that data.
We have someone asking, looking at the lung function long term, do you think it would be worth trying cycling the modulators?
I don't know that I can answer that question based on this data at this point in time. But I can see my colleague, Dr. Magora, is coming to talk about that one patient who passed away, so she can add more insight. So.
Yeah, this microphone's really far away. It was not. That patient had a similar positive response to being on ETI, and their death was not related to a respiratory outcome.
I'm going to ask a question which waxes into anecdote, so my apologies, but do you have any feel for any mental health adverse effects of ETI in people with advanced lung disease?
So we did not pull that out at this point in time. I do know we have patients who we have stopped the medication for or done dose reductions for their mental health. But that we did not find that at this point in time. I think if we pulled the data from if you went to about now, which is hitting that 5-year mark, which I intend to eventually look at, maybe next year we'll have that update. Then we might be able to pull some of those patients. I will also say that we did look also for dose reductions related to people on antifungals, but that actually did not, as far as we felt, that did not necessarily impact our group, because theoretically you should be getting the same dose. It's just you're making the adjustment based on the absorption.
And I'll ask one last question. Did you use a mix of clinic spirometer and home spirometer data? And if so, how did you ensure quality control?
So we did. We did have a few patients who did use home spirometry, and I will say we did probably put a trust in the center that did it, that we collected important information, but I think that was at this point, we felt that was the best way to get the data out there, because we did have some patients who did not show at all for in that first or even second year because of nerves about COVID and being in telehealth. So I will say that the number of people who submitted home spirometry as their readings were actually quite small. It was probably only 5 or 6 patients total compared to the entire cohort.
Great. Thank you to Dr. Cohen for that wonderful presentation. So I'd like to welcome our next speaker today, Dr. Valeria Dacco, Medical Director of Cystic Fibrosis Pediatrics in Milan, Italy.
Okay, and this, thank you, and this will change. Good morning, everyone, and thanks to the organizers for the invitations. These are my disclosures. In recent years, the development of CTR modulators have radically improved the natural history of cystic fibrosis. Both clinical trials and new aerial data have demonstrated that the triple combination with eladacaftor, abacaftor, tezacaftor is highly effective in improving lung function, reducing respiratory symptoms and the frequency of lung exacerbation, enhancing nutritional status, and overall improving patient quality of life. Traditionally, forced respiratory volume in 1 second has been used to assess lung function changes, and we know that patients with ETI may present an improvement in FEV1 in a range of 8 to 14 percentage points. But we know also from our clinical experience that some patients do not achieve a clinical meaningful improvement in FEV1. And this finding raises the question about whether this lack of improvement indicates a reduced responsiveness to the treatment or an insufficient sensitivity of FEV1 in detecting treatment response. In the last 10 years, lung clearance index has been increasingly used since it provides information from multiple about global measurement or ventilation immunogenicity and reflect anomalies of the smaller airways that are the site of early lung injuries in CF. So we can consider that lung clearance index is more sensitive than spirometry, particularly in patients with mild or moderate lung disease. In this context, the aim of our study was to evaluate the real-life effectiveness of elexacaftor, tezacaftor, ivacaftor triple combination treatment using both FEV1 and lung clearance index 2.5 as measure of lung disease outcomes. For this purpose, we designed a prospective study. We enroll all patients regularly followed at the CF Center of Milan who start ETI treatment between December 2019 and March 2022. This patient underwent spirometry and nitrogen multiple breath washout tests both before and 6 months after starting ETI treatment, in addition with normal routinary controls. The study outcomes of our analysis were the 6 months differences in FEV1 and lung clearance index 2.5, and our patients were divided in 2 groups according to the magnitude of the achieved improvement in FEV1, below or equal or above a minimal clinical important difference. We define as a minimal clinical important difference a 6 months absolute change in FEV1 greater or equal to 3%. The data of our analysis are expressed as median, and the statistical significance of the differences was assessed using the Wilkinson sign rank test. Here you can see the patient characteristics at baseline. We enrolled 95 patients, nearly 44% were female. Their median age was 20/8, and approximately 50% was homozygous for delta F and were previously treated with other modulators. The BMI of this population was fine. Only 7 patients were underweight, and the percent predicted forced expiratory volume in 1 second, median value, was 86. Only 8 patients had a severe lung impairment. The lung clearance index 2.5 median value was 12.4, and Cystic Fibrosis Quality of Life questionnaire revised regarding respiratory domain was 83. Let's see our results. Here you can see the changes in percent predicted FEV1 and lung clearance index from baseline and after 6 months. In our population, the absolute changes in percent predicted forced expiratory volume was plus 15. Lung clearance index improved too by 3.8. And if we consider the relative changes, percent predicted forced expiratory volume in 1 second improved by 90.2, and lung clearance index by 28.9. Here you can see the distribution of FEV1 after 6 months of treatment. As you can see, 10 patients did not reach the minimal clinical important difference that we define at 3%, and 8 patients did not improve their FEV1. In this slide, we can see better the difference in this population. 85 patients had an improvement in FEV1 and reached the minimal clinical important difference that we define at 3%. As you can see, their percent predicted forced expiratory volume was improved by 16, and lung clearance index 2 improved by 4.4. Cystic fibrosis questionnaire regarding the respiratory domain improved to of 11.1. But if we can go to see the results of patients who did not reach the minimal clinical important difference of 3%, as you can see from the picture, this 10 patients did not improve their FEV1. Someone had a decrease, but if we consider a lung clearance index, also this patient improved by 0.5, 2.4, and cystic fibrosis quality of life respiratory domain improved too by 16.7. But who are these patients who did not achieve the minimal clinical important difference? You can see here the baseline characteristics of this population. We can see that no one of these patients had a severe lung function impairment, but for the other things, there are no particular difference. The sweat chloride concentration had a reduction also in this patient after 6 months of treatment. And so, in conclusion, we can say that after 6 months, nearly 90% of patients treated with ETI show a significant improvement in lung function as measured by both forced respiratory volume and lung clearance index 2.5. And the remaining 10% of patients had a reduce in lung clearance index 2.5 and decreased respiratory symptoms according to the cystic fibrosis questionnaire domain. So our findings highlight the positive impact of ETI treatment, showing a substantial enhancements in lung health for the majority of patients. And lung clearance index 2.5 has proven to be a more sensitive respiratory indicator than FEV1 on patients undergo ETI treatment, especially in those with mild or moderate lung disease. Thank you very much.
This presentation is now open for questions.
Pierre-Régis Burgel from France. Very nice presentation. Maybe I missed it. You had 10 patients with no increase in FEV1
Yes.
over 3%.
Yes.
Do you have any clue on the characteristics of these patients? Were they older, at the lower FEV1?
As you can see from this slide, there were no difference with the other total population. They were no older, but I can say you that in another study we have done, people older have a worse response in FEV1 respect to the other patient, not in this population, because the median age in this population was 20.5, as it was not different in the 10 patients that we have seen.
Thank you.
I have a question. Thank you very much. That was a really wonderful presentation, and interesting to use LCI in the older patients as opposed to young, mild lung disease patients. So as you're well aware, there's a lot of controversy over how to define MCID, both for FEV1 and for LCI, and you decided to use a relative change. And I wonder about performing an additional analysis using an absolute change, because they both have pluses and minuses, but the relative change can be influenced by the baseline value. So for example, in LCI, there's more variability the higher the baseline LCI is. So you in fact may be seeing a confounding effect of baseline LCI. So you might want to consider an absolute MCID as well.
Yes, I think you are right, yeah.
We have someone coming up for a question. In the meantime, do you regularly use LCI in your patient population?
Yes, we have children, and you use regularly in children. And now that it's possible to use this treatment in younger and younger children, I think that LCI is very important. because it's the only way to evaluate the treatment, because FEV1 is very difficult in children when they are younger than 6 years.
Just following up on the MCID discussion, I was just wondering how you came up with the 3% MCID for FEV1, because that's not usually what people think is the MCID for FEV1. There are certainly discussions whether it's 10% or higher than 10%, but 3% seems to be incredibly low. So I was wondering how you came to that conclusion.
We have found in literature that there are some study using this, and we decided to use this for uniform. But you are right, it's not a good response.
Remember, if you have any questions, feel free to post it in the app as well that we're keeping an eye on, or if anyone wants to come up to the mic. So it looks like I have a question. So there were dramatic improvements in FEV1 and LCI compared to other cohorts. Did you look at treatment? Oh, this may have been a question, sorry, for the previous speaker. Sorry about that.
You could ask it again.
Yeah. Any questions from you? Okay, I think that's it then. Thank you, Dr. Dacko, for that presentation.
Thank you very much.
So our next speaker is Dr. Valerie Waters from Sick Kids Hospital in Toronto, and she'll be speaking on the results of the PIPE study, which was a randomized, double-blind, placebo-controlled trial of oral prednisone as adjunctive treatment in pulmonary exacerbations. How do you... Oh, maybe I should press the start.
Okay, great. I'd like to thank the organizers for the opportunity to present the results of the PIPE study on behalf of all my co-investigators in Canada. No. How do you advance?
How do you advance the slides?
Oh. All right, I have no disclosures related to this presentation. So as very well described by the other speakers today, pulmonary exacerbations are known to be associated with significant morbidity and mortality in people with CF. Over 50% of the decline in FEV1 over the lifetime of a patient is associated with pulmonary exacerbations treated with IV antibiotics. And there's often incomplete FEV1 recovery following exacerbations. We and others have shown that about 25 to 30% fail to recover back to baseline or 90% of baseline FEV1, and only 40% may fully recover lung function. And although we know very well that modulator therapies reduce the risk of pulmonary exacerbations and their frequency, studies have shown that ivacaftor, for example, does not improve the rate of lung function recovery in those who are having pulmonary exacerbations. So the factors associated with poor lung function recovery have generally been associated with increased inflammation. In a previous study that we have done, we've shown that elevated markers of pulmonary inflammation, specifically sputum neutrophil elastase, was associated with failure to recover FEV1 at day 14 of IV antibiotic therapy. Others have also shown that higher CRP and sputum neutrophil elastase is associated with increased risk of subsequent exacerbations, and that treatment failures are associated with increased serum white count and CRP. So there is one other study that has looked at the use of anti-inflammatories during pulmonary exacerbations, and that's the DOVI trial. The DOVI trial was a small pilot, a randomized controlled trial of the use of prednisone, 2 milligrams per kilogram per day, started at the beginning of the pulmonary exacerbation from day 1 to 5, and compared to a group that received placebo from day 1 to 5. And as you can see from this figure here from their publication, the lung function did not differ statistically between the two groups at day 6 or at day 14 of therapy. Our question, though, however, was in those who were not responding to IV antibiotics, would the addition of oral prednisone as an adjuvant therapy help improve the recovery of lung function during exacerbations, given what we know about failure to recover in those with high inflammatory markers? So this was a study that was designed. It was a randomized double-blind placebo-controlled trial that occurred from May of 2017 to December of 2022. It occurred at 14 Canadian CF centers, originally starting with 6, and then 8 were added during the course of the study due to low enrollment. Exacerbations were studied that were treated with intravenous antibiotics, and the analysis was done as an intent to treat analysis. It was a Health Canada monitored study, REB approved at all sites, monitored by DSMB, and registered with clinical trials. So this figure illustrates the study design of our particular study. So patients were enrolled at day 0 of their IV antibiotic therapy. They were followed until day 7 when they had a repeat lung function done. If they had achieved greater than 90% of their FEV1, of their baseline FEV1, they were called responders. And these patients were simply followed and observed until day 14 and at the 1-month follow-up visit in clinic. If, however, they did not achieve at least 90% of their FEV1, they were called non-responders. And those patients were randomized to either placebo, which were lactose capsules, or prednisone, 2 milligrams per kilogram per day, divided twice daily to a max of 60 milligrams. The primary outcome was measured at day 14 of the IV antibiotic treatment, and then they were followed at the 1-month follow-up visit in clinic. So here illustrated on this table was the primary outcome as well as the secondary outcomes that we collected during the course of the study. So the primary outcome was the proportion of subjects who recovered greater than 90% of their baseline FEV1 at day 14 of IV antibiotic therapies. As secondary outcomes, we also looked at lung function recovery at day 30. We looked at absolute changes in lung function, quality of life measures, serum and sputum inflammatory markers, duration of IV antibiotics and hospitalization, adverse events, withdrawals, and the time to the next IV-treated pulmonary exacerbation. This table illustrates the complete inclusion and exclusion criteria for this trial, and I'll highlight just a few of the important points. So for inclusion, these had to be exacerbations treated with IV antibiotics, and they had to have at least a 10% relative drop in baseline FEV1, and that's because the primary outcome was looking at return to baseline FEV1. In terms of exclusions, we excluded those who had ABPA or asthma as determined by the treating physician because we did not want to look at the effect of steroids on the asthma phenotype. We also excluded those patients who had organisms that potentially could be concerning for invasion, including Burkholderia sinocepacia and Mycobacterium abscessus. We excluded patients who were already on corticosteroids before enrollment, and patients who are at increased risk of side effects due to steroids, such as those with pathologic bone fraction, hypertension, GI bleed, organ transplantation was excluded, and patients who were on lumocaftor ivacaftor, only specifically this modulator because it has an interaction with steroids due to the LUMA component. During the course of the study, patients who were randomized to the prednisone were monitored at day 7, day 10, and day 14 of treatment with blood pressure monitoring and urine glucose. If the dips were greater than 2, they had serum glucose, and the information was provided to the treating physicians. And then now the results. So here's the consort diagram to illustrate the patients that were screened and eventually randomized into the trial. So during the course of the study, over 1,600 pulmonary exacerbations were screened for enrollment. You can follow the consort diagram down, and you can see that in the end, about 86 were responders, and an almost equal proportion were non-responders. And of those, 76 were randomized, 38 were in the prednisone arm, and 38 were in the placebo. But there were 2 that did not have the day 14 lung function. So there was 36 that were available for analysis in the placebo and 38 in the prednisone arm. And it's important to note that the vast majority of patients, 95% of participants in the prednisone took all the doses, and 92% of the participants in the placebo arm took all the doses of drug. So this table illustrates the demographics of both the responders that we have here on the left, as well as the non-responders that were randomized to prednisone or placebo. And I'll just point out that the mean age here is around 25 and 22 in the 2 arms. The genotypes are expressed here. A large proportion of patients were co-infected with Pseudomonas. Very few patients were on modulators, and this was due to the fact of the timing of the study was predating the wide availability of use of highly effective modulator therapy in Canada. So only about 10% were on modulators of some kind. And baseline lung function was about 72 or 73 in the prednisone and the placebo arm. So for the primary outcome, the proportion of patients that achieved baseline, 90% of baseline FEV1, we have 50% in the prednisone arm and 39% in the placebo arm, and this was not statistically significant between both groups. This figure illustrates the absolute changes in lung function with FEV1 on the y-axis here. The purple line is the prednisone arm. The orange line is the placebo arm, and you can see that they were very similar from baseline to day 0 to day 7, day 14, and day 30. And there was no statistically significant change between day 7 and day 14 between both arms, as well as day 7 and the 1-month follow-up at day 30. We also looked at quality of life with 2 measures. We used the CFQR respiratory domain as well as the CRIS score. And you can see again that the prednisone is the purple arm and the orange is the placebo. So very similar changes for the respiratory domain over the time points, and similar for the CRIS score over the time points. And again, no statistically significant difference between day 7 and day 14, as well as day 7 and day 30 for both the CRIS score and the CFQR between both treatment arms. And finally, we looked at time to the next pulmonary exacerbations treated with IV antibiotics. And this Kaplan-Meier curve illustrates the time until the next episode. Again, prednisone in purple, and the hashed line of orange is the placebo. And these lines were not statistically significant difference between both groups. The duration of the IV antibiotic treatment was very similar again between both arms, 17 days for prednisone, and a placebo had 16 days and not significant again. This one's slow, I know. It's a slow slide, yeah. This one's a slow one. We also looked at serum inflammatory markers, specifically serum white count, serum neutrophil count, and CRP. And you can see here that from day 7 to day 14, there was a significant increase in the white count and the neutrophil count in the prednisone-treated patients. As expected, neutrophilia is what we have previously seen in other studies and what we clinically see as well. But there was no difference between groups for the CRP between day 7 and day 14 of treatment. In a selected group of patients at study sites where it was available to do sputum processing, we also looked at sputum inflammatory markers, specifically neutrophil count, neutrophil elastase, and IL-8 measures. These are small groups, a subset of the total numbers, but there was no difference between the neutrophil count between both groups. There was a small signal for a difference in the drop of neutrophil elastase in the prednisone-treated arm compared to the placebo arm, but no difference in the change in IL-8 between the 2 arms. In terms of adverse events, there were serious adverse events, but none thought to be related to treatment, and there was no difference in the proportion of patients with adverse events in one arm versus another. These were not statistically significant, these 2 changes. So there were limitations to this trial. Probably the most significant is the small sample size. FEV1 recovery at day 14 was calculated using estimates of 30% placebo rate versus 60% for prednisone. And with that, there was a target of 84 randomized participants. There were actually 76 that were randomized before the study was ended on advice from the DSMB due to slow enrollment. And the slow enrollment was due to a number of multiple factors, including the COVID pandemic, as well as the introduction of modulator therapies. Another limitation is there was a small percentage of patients who were on modulator therapy, which may limit the generalizability of the study, but in those patients who are having exacerbations, I think this data is relevant. The primary outcome was based on recovery of baseline lung function. And there is a very nice recent paper by Dr. Haushi in JCF, which comments on sometimes the arbitrary nature of recovery of lung function when there's an absence of a comparator arm. We were fortunate that we did have a comparator arm, and we also looked at absolute changes in lung function and did not note a difference between treatment groups. And finally, those who were able to produce sputum samples was a small subset of the larger patient population, which was another limitation. So in conclusion, this trial shows that adjuvant oral prednisone does not improve lung function recovery following exacerbations in those not responding to IV antibiotic therapy. We also did not see an effect on secondary outcomes, including changes in lung function, quality of life, duration of treatment, time to subsequent exacerbation. In terms of inflammatory markers, we did see the expected neutrophilia that has been previously noted with prednisone treatment. And although we didn't see an effect on neutrophil count or IL-8, we did see a small signal for neutrophil elastase, but be mindful these are small numbers and there were some outliers. But we did not see an increase in the proportion of patients with adverse events. So I'd just like to end by thanking the huge number of people, all the co-investigators in this trial across Canada, and in particular the senior investigator, Dr. Felix Ratchen. There is an enormous number of very dedicated research coordinators. I could not name them all, but to point out those at the sponsor site at Sick Kids, Nancy, Amara, Cheryl, and Anthony, who worked tirelessly on this study, and then the patients, the families, and then the funders, which were CF Canada and CF Foundation. And I'm happy to answer any questions.
Thank you very much, Dr. Waters, for that presentation. And now the floor is open for questions.
Pierre-Régis Burgel from France again. Congratulations, such an incredible study. Given that in other diseases, in other bronchial diseases such as COPD, for example, it's been there forever, the question of whether adding steroids improve patients or not. And the answer in the COPD literature at the moment is based on eosinophils in the blood. So here you showed white blood cell counts and you showed neutrophil counts. Do you have access to eosinophil counts?
That is a very good question. Many of these sites would have had differentials done, which would have included eosinophils. We do not have that in our REDCap database. Would it be possible to get it? It may be possible to go back and get that because they're clinically done tests. So it is possible that we can get that. We were trying to exclude the asthmatic type phenotype, right? So we were trying to exclude ABPA and asthma. But I get your point. I don't have that data. Is it possible to get it? Potentially so.
I think it would be most interesting to have this data.
On that note, something I was curious about, and I know a lot of centers don't do this, but coming from McMaster, I have to say sputum eosinophilia. So we use this a lot in COPD and asthma to determine when to use prednisone. So it'd be very interesting in the CF group. It's something, I've thought about a lot. So I'm not sure if there's any interest.
That we do have. So in those patients who could produce sputum, which was a subset of the group, cell counts were done. So I'm showing you the percent of neutrophils, which the vast majority were in the 99% were neutrophils, but there is a subset. We do have the other cell counts. So there is a subset that have eosinophils as well. Clearly not in the 90% range, but we do have the full cell counts for that subset of group that we have sputum on. So we can look at that.
Okay, I was going to ask, so do you know if those patients were steroid responders? Or are you not sure?
I'm
yet?
not sure. I'd have to go back and look at that. But in our group, like the vast majority is it neutrophils. Like they're greater than 90% are neutrophils.
Kevin Kirschner from Atlanta, Georgia. Quick question. What was the dose of oral steroids again?
2 milligrams per kilogram per day to a max of 60, and the dose was divided BID, or twice daily.
Hi, I have a question. Really fantastic job. We've all been waiting for such a study for so long, and I know it was so hard to recruit patients. So I hope you can disseminate this important result in a really way that will change practice. I'm a little bit grasping for straws here, but I was wondering if an analysis separating responders from non-responders and looking at predictors of responding would be helpful, such as sputum eosinophilia. Or the other thing I was thinking of is you very importantly excluded those with a diagnosis of asthma or ABPA, but asthma is sort of or bronchial hyperactivity is sort of a slippery slope. And would there be any, if you collected data on con meds at enrollment, were those who were responders more likely to, say, be on ICS-LABA?
So the question of looking at responders and non-responders is our next analysis, which Brad, where he is. We're working on that once we get the interventional part done, but this was part of a larger study that Dr. Kwan was funded for to look at biomarkers. So we have extended biomarkers and data for the entire group. Okay. So we will look at the responders and non-responders once we get this prednisone randomized part done. That's our next project. And your question about the con meds, we do have con meds, so we will be able to include that in any analysis for responders and non-responders. Yeah.
Brad, no pressure.
Yes. Seth Walker, Atlanta, Georgia. My question is about all the other questions. So do we stop using prednisone for exacerbations, or do we keep looking for that magical subset of people that will respond and have significant long-term outcomes?
Oh, well, it's a good question. Probably not for a pediatric ID person, really. But I did see there have been surveys of what people's practice are for using steroids during exacerbations, and I think it varies quite widely from center to center. And I do think that there's a lot of variability. There may be some who may still use it, and others who will not use it. So I don't know if I can comment and say what you should do. But we have not, at least during exacerbations, found that it has benefit of any of the markers that we can measure. So, of course, every patient is different, and there may be select situations, but I feel that's outside my bandwidth.
A few questions here. How did you control for asthma or a history of bronchodilator responsiveness?
Okay, so asthma was an exclusion criteria. And this was left in the treating physician. If the treating physician defined that this particular patient had an asthma phenotype with this exacerbation, they were excluded. And the reason we left this without a specific definition was because from my understanding, asthma is sometimes difficult to define. So if the treating physician felt that there was an asthma phenotype for this exacerbation, it was an exclusion criteria. As well, ABPA for this exacerbation was an exclusion criteria. That answer the question? Yeah.
Any interest in looking at early steroid use? So repeating the trial, but starting steroids on admission. And also were people with impaired glucose or CF-related diabetes included or excluded?
Okay, so for the first question, that was the study design of the Dovey trial. So the Dovey trial was right from the beginning, from day 1 to 5. Patients were started on steroids, and it was a small pilot study, 12 in each arm, but they did not notice a statistically significant difference, although they noticed a trend in the FEV1. But when they did a power calculation, they felt that it would require 250 randomized subjects to see a 4 percentage point difference at day 14. So we didn't want to repeat that study because it had looked at that question initially. So that's why we designed it this way, to try to avoid the systemic side effects of steroids in all patients and just focus it on those who were non-responding. Because we do know that those who are not responding at day 7, there's only 30% of those that will respond back to baseline lung function at day 14, and that's from our historical Toronto CF database analysis that we did. Your second question was about impaired glucose tolerance. So initially, diabetes requiring insulin was an exclusion criteria, but it was removed during the course of the study through Health Canada to try to increase enrollment and try to increase the number of patients we could randomize. So it was excluded as an exclusion criteria. Removed.
Great, and that's it for questions. Thank you very much, Dr. Waters, for that fantastic presentation. So for our last speaker today, I'd like to reintroduce my co-moderator, Dr. Margaret Rosenfeld, who's a professor of pediatrics at the University of Washington.
Okay, great. Excellent. All right. Thanks so much. So, oh, that's the wrong presentation. That is not going to help. I'm not going to be very good at this one. Let's see. Yes. Okay, I'm feeling a little bit more confident in this presentation. All right. So I will disclose funding from the U.S. Cystic Fibrosis Foundation for this work. So in terms of background, the pandemic mostly had negative side effects, but one of the silver linings was the ability to think more creatively and innovatively about home monitoring and telehealth, which was mostly in the clinical care venue, but definitely fed over into more innovative study designs for clinical research, which is what I'm going to be focusing on today. So home spirometry is a promising endpoint for CF clinical trials that might either be fully or partly remote, potentially reducing the burden of in-person visits and allowing for more frequent measurements. But we first have to answer the question, how accurate is it? Is home spirometry garbage in, garbage out? Or could it be a meaningful clinical trial endpoint? So the PROMISE study, which is having multiple presentations throughout the conference this year, is an ongoing North American, multi-center, longitudinal observational study of the clinical effectiveness of ETI in children 6 to 11 years of age and teens and adults, those who are 12 and above with CF. And I'll just say, so there's the main PROMISE study, which was ages 12 and above, and the pediatric study, which is ages 6 to 11. And so during this presentation, if I refer to adult, that actually means teens and adults over 12 years of age. A 12-year-old is definitely not an adult, but that's just the moniker from the PROMISE study. And then peds is 6 to 11. But I'll try to be clear as I go through. So during the pandemic, all of a sudden we had to rapidly introduce home spirometry as a study procedure because this aerosol generating procedure was not going to be tolerated. And this provided an opportunity to compare home to office spirometry in a research setting. So the objectives of this current analysis were to evaluate the accuracy, or what we would call bias, of home spirometry relative to office spirometry. So that's the difference between the home and the office FEV1 Z-score. I'm presenting Z-scores rather than percent predicted because we're all pushing very hard for the field as a whole to change to Z-scores. And then secondarily, to identify predictors of accuracy, specifically age group and FEV1 Z-score. So participants in the PROMISE study, both the PEDS and the adolescent adult study, were instructed to perform measurements using the MIR Spirobank spirometer and the Zephyrex Breathe Easy app. This is the same spirometer and app as the USCF Foundation was giving out on a clinical basis. But these spirometers were separate, typically within 1 week of the office measurements that were performed at 3, 6, and 12 months after initiation of ETI. So when I refer to baseline, that's baseline on therapy, not baseline pre-initiation of ETI. And they performed 2 different measurements, UNCOAST measurements, which were using the in-app instructions only, and then coach measurements, which were remotely coached by trained research staff via video or phone. Then the FEV1 was graded automatically by the Zephyrex software, and we refer to acceptable as those with grades A, B, or C, according to the ATS-ERS 2022 criteria. And we used the GLI, or Global Lung Initiative 2020-12 reference equations to generate Z-scores. We used the other racial and ethnic category, so it's sort of like a race-neutral approach. And then we used a general additive mixed effects model with t-distributed errors. That just brings in the error margins a little bit by age group. So less than 12, 12 to 18, 18 to 30, and over 30 to evaluate age group and FEV1 Z-score as predictors of accuracy. So there were a total of 612 promised participants who had a home spirometer, and about 390 of them had paired acceptable home and office measurements. Those were divided between 284 who were 12 years of age and older, and 105 who were children ages 6 to 11, and slightly more coached than uncoached measurements in both groups just by study design. I'm sorry this is so small, but these are the baseline characteristics of the participants who contributed the paired measurements to the analyses. And importantly, I think you can see that the mean age of the adults was 23 years, and that's the cohort that's 12 and above. And for the pediatric, the mean age was 9. The baseline FEV1% predicted was 88% predicted in those 12 and above, which corresponds to a Z-score of minus 0.95. And for the pediatric 6 to 11-year-olds, their mean was actually 109% predicted, so that's a positive FEV1 Z-score of 0.77, and then the cohort was 94% white. Excuse me. You know, this is too bad. This is an older version of the presentation, so it doesn't have everything I wanted on it. Not quite sure how that happened, but I will just talk it through. In terms of the acceptability of home measurements, what you can see was that overall the acceptability was quite high, both for coached and uncoached measurements, ranging from in the 80% in the children less than 12 years of age to really 96, 97% in those over 30 years of age. And that there wasn't much difference in the proportion of acceptable measurements between coached and uncoached measurements. Now, this is only whether they had a grade of A, B, or C, and doesn't say anything about the accuracy or bias. So you'll be seeing that in a minute. Okay. Why isn't it advancing? Thank you. This next slide looks at the longitudinal trends in grade or acceptability by age and visit. And what you can see is the pediatric cohort on the left and the adult cohort on the right, with coached measurements on the top and uncoached measurements on the bottom. What you want is everything to be yellow. That's grade A. And you don't want anything to be black, which is unacceptable measurements. And what you can see is in the adults, both for coached and uncoached measurements, there seemed to be a learning curve with more yellow and less black over time. Interestingly, we did not see that in the pediatric groups, where there didn't seem to be any improvement over time with repeated measurements. Thank you for the technical assistance. Okay, so this is kind of the meat of the results, this slide and the next one, where now we're using our modeling to display the estimated difference between home and office FEV1 Z-score among the coached and uncoached in different ages. So let me orient you to the slide. You can see that the coached measurements are on the top, the uncoached measurements are on the bottom, and then age is less than 12 in the bottom row of each of the coached and uncoached, going up to over age 30 at the top. And you can see a couple of important take-home messages. The first one, so also a mean difference of 0 is on the far right, and then the degree of underestimation of the office value by the home value is seen by a greater distance from that mean of 0. And so you can see that in both coached and uncoached measurements, it was the under 12-year-olds who had the greatest underestimation of FEV1 Z-score with the home measurements compared to office measurements. And there was really quite little difference in the adults over 30 years of age. So that's the first thing to notice. And the second thing to notice is that there was a bigger difference between the coached measurements on the top and the uncoached measurements on the bottom by lower age. So particularly among those 6 to 11 years of age, there was quite a big difference between the coached measurements and the uncoached measurements. Not sure how to, okay. Thanks, just keeps happening. Okay. And then the second kind of take-home result is that this is looking at the difference between home and office spirometry, not only by age group, but by FEV1 Z-score. So you can see the less than 12-year-olds is in the top left, and coached is red, and uncoached is blue, and then we have progressively older ages. And a number of important trends are observable here. That is, first of all, for all of the different age groups, there was more underestimation of FEV1 Z-score at home with a higher or greater degree of lung function. So the better your lung function is, the more likely FEV1 was going to be underestimated by home spirometry. The second is that you can see that the effect was particularly largest in the 6 to 11-year-olds, in whom there was a huge effect of FEV1 Z-score, and there's also that much more pronounced effect of coaching that I mentioned before. Okay, I'm glad I'm getting towards a conclusion since I'm having such trouble advancing slides. My apologies. So in conclusion, measurement acceptability was high across all age groups, between 83% in the 6 to 11-year-olds to 97% in the over 30-year-olds, and was not significantly different between coached and uncoached measures. There was a learning effect seen for the teens and adults, but not for the children, ages 6 to 11. On average, the home spirometry values were significantly lower than office values, so underestimation. The difference was greatest for children 6 to 11 compared to the older cohort, particularly those with preserved lung function and for uncoached sessions. So we hope that these results can inform the design of future clinical trials considering home spirometry as an endpoint. Seem to advance. So some important limitations need to be acknowledged. First of all, with the need to pivot rapidly to home spirometry and incorporate it into the PROMISE study during the pandemic, we really had no ability to develop or implement comprehensive training materials for participants or research coordinators. It was kind of on the fly. So with more attention to training and education, the results may vary. There was some variability in the time between home and office measurements between individuals. We, of course, could not partition the sources of measurement differences, so we couldn't sort out what was due to inherent biologic variability, effort or technique, and the device itself. But the fact that the home measurements were generally lower than the office measurements and that coaching narrowed this gap does suggest that effort or technique plays an important role. Still more work. Oh, I did it, yay, okay. So in terms of next steps, we'll continue to evaluate the longitudinal changes in accuracy as participants continue to be followed in the ongoing PROMISE study. But I did also want to give a shout out for the ongoing outreach study, in which enrollment was just completed, and so we'll have results to present early next year, which is a prospective study evaluating the accuracy, reliability, and feasibility of coached and uncoached home spirometry in U.S. patients with CF who are ages 6 to adult as a clinical trial endpoint. We're also looking at home height and weight. And if I can, I would like to acknowledge all of my colleagues involved in this. Do you want to see if you can advance it? Okay, thank you so much. So in acknowledgement, I would very much like to acknowledge the USCF Foundation for funding, the participants in PROMISE and their families, the PROMISE sites, and the research coordinators who did all of the heavy lifting with the remote coaching, as well as Colin O'Rourke for incredible statistical analysis. So thank you very much. Time for questions.
Thank you, Dr. Rosenfeld. And whoever has questions, feel free to come to the mic or post them in the chat, which I'll be following.
Hello, I'm Erin Moore. I'm a CF mom. And I had a question about whether you've considered, instead of looking at absolute values, looking at the relative change when using home spirometry, because I know there is a difference. But from my perspective, even in clinic, rather than looking at the absolute values, we react to the change. And so if patients at home are doing it wrong, as long as they're doing it wrong consistently, you might be able to make some different observations, and I think that could be valuable in clinical research also.
Wow, you're like a plant in the audience. Thank you so much for that question, because that's exactly how my mind is working as well. So that is such a critical question. I think we need to think about home spirometry potentially as a different set of results as office spirometry. And as you just pointed out, if the changes are what we're caring about, then that's what we really need to focus on. So in the outreach study, what we're actually looking at as our primary endpoint is change, not just the absolute values. And there are other studies that are looking at that during exacerbations as well. So that is definitely the most important next step, and thank you so much.
I'm Mel Collins, Hartford, Connecticut. So this is a strange question that's probably not really legitimate, but just, after COVID-19 and we were seeing those lower results in our patients with home spirometry, but like Erin mentioned, right, trending appropriately over time. Is there any way to get a correction factor so that you would know if this is about this person's baseline that you've established when they're in clinic using our office spirometers?
So that is not a silly question. It's a really important question. And I think the answer deserves a little bit more research. So it's if you can have the home spirometry, an individual's home and office spirometry done rather contemporaneously, then you can develop a correction factor for that individual patient as long as they continue to be relatively steady at home. So that would be the way to do it. I worry that during exacerbations, for example, it's harder to do as good a blow, and so that correction factor may be off. So that's something to consider.
We have a few questions in the chat. Should home spirometry be used for clinical care in addition to research?
That is a big question. The answer is, I think, yes, but how? So actually, in another presentation I'm giving tomorrow, I'm going to give a shout out to 2 ongoing quality improvement projects assessing the use of home spirometry in clinical practice. So yes, I think there absolutely is a role, but we need to learn how to do it right and how to interpret it.
Okay, and you looked at Z-scores in your presentation. Do we know what the clinically meaningful difference in Z-score is?
That gets back to our prior speaker. No, there is not an established minimal clinically important difference for Z-scores. The reason for, nor is there really for percent predicted FEV1. People will toss out numbers like 5%, but I think that's a little bit of an oversimplification. The reason for using Z-scores is because percent predicted FEV1, the normal distribution varies by other characteristics like age, and that's taken into account for the Z-scores, so they're easier to interpret. But the MCID is not well established, I would say, for either one.
Okay. Another question, although home spirometry values were lower, was the degree of difference clinically significant? It looked like the degree of difference was mostly less than 1 to 2%.
Yeah, that's an absolutely great question. It very much depended on the individual. I wish I could show you some bland Altman plots, but particularly in the 6 to 11-year-olds, where there were some kids who had huge differences, and then those differences were far less in the older patients.
Okay. For the home spirometry reading lower, were you looking at percent of predicted FEV1 or absolute value when comparing it to office or clinic FEV1?
Right, so I'm sorry if that was confusing. We were using z-scores, so we converted everything into z-scores, and that's a way to look across different ages and have a meaningful result.
Okay. Was the update in firmware in the MIR Spirobank spirometer a factor during the data collection?
How about I don't know as an honest answer? I'll have to get back to you.
I'm just looking through. I think that is all the questions. So thank you very much,
Great.
Dr. Rosenfeld.
Thank you for bearing with my technical difficulties.
Thank you to all our 5 speakers today for those wonderful presentations, and thank you for all of you participating, and enjoy the rest of your conference.